fellowship has meant a lot to me, which I will talk your ear off about all over the evening and get to know you better. So I just want to give you a really quick orientation to my project. Try to keep it short. I don't think the current fellows have ever given a joint presentation where we didn't go drastically over. So I'm going to keep it quick. So Marian Arledge with Buncombe County Health and Human Services in Asheville, North Carolina. And I started my project about 2 years ago in partnership with WNC Health Network in Western North Carolina and their project WNC Healthy Impact. It began as a partnership between 16 nonprofit hospitals and 16 local health departments to complete really high quality community health assessments, community health needs assessments together. This was a relatively new requirement as part of the ACA for nonprofit hospitals. It's something local health departments have had experience in for many years, and it's a natural fit. This is happening nationally, and we want to capitalize on that in our part of the state and build capacity for it. So building capacity specifically for the local health departments, and also looking to create a model that could be easily disseminated to other low resource areas, so that health educators in local health departments would have the resources that they need to deliver a high quality product with as few staff as possible in a landscape where staff aren't growing off of trees. So to do the community health improvement process, this is the basic cycle. It'll probably look familiar to many of you in the room. The assessment part really begins with compiling health-related data, the needs and assets of a community. We move into the analysis and interpretation of that data, and then prioritize a small handful of issues that the community will work on for between 3 and 4 years collectively. And that's kind of how community health improvement as a whole works for accreditation requirements for local health departments and IRS requirements for nonprofit hospitals. We then move into collaborative action planning and evaluation and implementation. So much of this work is being conducted by local health educators in our part of the state. So it's an early part of my project in partnership with Heather Gates, Director of WNC Health Network. We wanted to look for these health educators, what do they really need to feel like they have the support and capacity to meet these roles well. We developed a basic survey asking them to rate a variety of capacities. This was built off of some work that Healthy Carolinians with Sarah Thatch had done looking at capacities for health educators. And they were asked to rank them both on how much confidence do you have to perform this, and also how important do you actually think it is to your job. Realized working with the 16 westernmost counties in North Carolina that my experience in Buncombe County was in many cases distinctly different from theirs. So for example, I had put on the survey collective impact. I'm obsessed with the collective impact model. And many other counties, for example, might have said, not 100% confident in implementing a collective impact model, but I also don't see it as critical to doing a community health improvement plan. So we conducted the survey, held a focus group, and the two most important needs that rose to the top were evaluation and accessing needed data. So they wanted more capacity to do those two things specifically. Some of these we were able to find for low to no cost, so bring in existing resources and training to the group to build their capacity without having to pay for a lot of travel and outside paid trainings. One of these was the NC Detect training, which we were able to access for free. They came out to Western North Carolina, and everyone got to learn a little bit more about how to use this disease tracking tool where they hadn't maybe had accounts or access to it in the past. So they're using that now. We also linked together with the Center for Healthy North Carolina, which Joanne can tell you all more about. And we're able to get a lot of the local health educators into the evidence-based intervention training, which had information on how to access data and also some information on evaluation, but that wasn't the primary focus. So for evaluation, we wanted to find something that was accessible, low cost. You didn't have to have a doctoral degree to learn how to just get up and use it. Something that wouldn't detract a lot from their regular jobs in health departments. In 2014, I went with a representative from Mission Hospital to speak about some of our other work with WNC Healthy Impact at the National Network of Public Health Institute Improvement Training. And at that training, we were exposed to a number of sessions on results-based accountability, and seemed like everyone at this conference, hundreds of people were abuzz with RBA talk, and we felt totally behind. So we went home and learned much more about it, and the results scorecard that goes with it. And just basically in a nutshell, it makes evaluation as simple and accessible as possible. It distills a lot of CQI models, other evaluation models down to their core elements, and just asks you to look at the quantity and quality of both your effort and your effect. So how much, how well, is anyone better off? Recognizing that oftentimes in program evaluation, we're looking at measuring what's the easiest thing to quantify. So number of meetings held, number of stakeholders contacted, the things that add up quickly but are really the least meaningful, but we have the most control over them and you can count on. On the flip side, looking at if anyone's actually better off, looking at the quality of your effect. So what percentage of people in your program actually met the desired outcome is the hardest thing to control. We know there are nearly infinite contributing factors in a person's life. So for example, working in a drug treatment program, you know that your intervention isn't the only thing in that person's life that will decide how they recover from drug addiction. But that is the most meaningful data. So we worked with the communities to think about how to get their program data, think about it in an entire system, and then relate that back up to their population level goals. So their community health assessment showed that childhood obesity was a priority. How do the program results of their portfolio of projects relate back up to the big goal, which is something that can be hard to show in a community health improvement plan. There's also an amazing software tool called Results Scorecard, and between NC Center for Health and Wellness and WNC Health Network, they were able to purchase many licenses for this software and distribute them in our part of the state, and are now doing trainings on how to use it. And it basically takes everything I just described and puts it into a very easy to use, colorful, interactive, online, cloud-based software. So you can see your population health data, your portfolio of programs, and how they're trending, if you're turning the curve towards your desired result. Which is really exciting, you know, especially if you're living in an area where you have not had access to these tools. This can be a real game changer. So we held a lot of trainings. That's my mentor, Heather Gates, who was a pleasure to work with and has really guided me a lot through this fellowship, and I've loved having the opportunity to work with her on this project, speaking to some of the health educators. We gave a variety of statewide and national presentations on the work of Healthy Impact. So snapshot. I'll add this presentation to this slide in the future. Speaking to the distinguished room. And to continue the work, I'll just leave by saying, realizing that since the beginning of my fellowship, the field has changed dramatically. The face of local health departments and local health educators continues to change. For example, the team of local health educators that I managed at the beginning of my fellowship are now performing their same function through a contract at MAHEC. So the field is constantly changing. So as a way to continue this work, we're now working with Western Carolina and MAHEC on a primary care certificate program for nurses, and I'll be teaching the population health course. And just a realization on my part that these skills in basic community health, evidence-based intervention, finding, evaluation, can be applied to many audiences. It doesn't have to be the role of the local governmental health educator. It can be spread and should be spread more broadly. So I look forward to working on this course starting in the spring. If you'd like to enroll, it should be a good course. So that is a quick snapshot of 2 years of work. And we can talk more about advice, but basically stay flexible, because when I go back and read my application and my original project plan, it's almost, you just have to laugh at how much has changed. But as long as you have the relationships and the connections and the resiliency to stay flexible, the work continues to be enjoyable and fruitful.
Great.
Thank you all so much.
Thank you.